want to go ahead and introduce our next speaker, Yarnell Beatty, to speak on additional legislative issues affecting oncology here in Tennessee, who is Mr. Beatty also holds a seat on the Compliance Committee of the Physicians Advocacy Institute and Executive Council of the Tennessee Bar Association, the Health Law Section. So, next speaker, thank you.
Good morning, and thank you for having me today. That's better. Today's agenda is divided into three distinct parts. The first part, I'm going to take a brief look at some of the cancer treatment specific legislation that's been introduced in the state of Tennessee. The second part, I'm going to do a blitz through a lot of different laws that passed during the 2016 legislative session that involve your practice, involve your license as a physician, and involve your patients as well, having an impact on those. So with that, let's start with the cancer treatment specific bills. The first you've heard a lot about in the previous presentation, the co-pays for cancer medications. So I'm going to move on to the next one, which is the Cancer Patient Choice Act 2. This is nearly identical to a bill that was filed in 2015. It would have required commercial plans and TennCare to cover a proton therapy for breast and prostate cancer under a hypofractionated protocol as part of a clinical trial or registry. It did establish the number of treatments that would be covered, and it did have cost control measures in it in terms of trying to cap the expenditures for the TennCare program. The bill was viewed as, yes, the M word, a mandate by the legislature, and was being debated parallel to another bill that I'm going to talk about in part 2 of my presentation that I want you to keep in your back pocket. It has a lot to do with what we're talking about today in terms of cancer treatment legislation. The bill was amended. It took TennCare out of the bill, which was an opportunity to try to reduce the fiscal note on a bill. Every bill that's introduced is given a fiscal note, and the fiscal note is the amount of state expenditures that would have to be made and put into the budget in order to fund the legislation that passed. Having a fiscal note means the chances of passage would greatly reduced, because then the legislature has to look at all of the different cross-section of legislation that has to be funded, and then they have to make a decision as to which one of those will be funded. So it's called being put behind the budget. So even if it passes, it's got to be funded as well. So that makes it challenging. So this particular bill failed in the subcommittee, and the reason why was there was some doubt by the members of the committee as to the efficacy of proton therapy. And questions arose as, okay, if we fund this, is the return on investment going to be a good one? I mean, is the cure rate from proton therapy so much better that we need to fund paying for more expensive therapy? So that was the challenge there. Another bill, Senate Bill 1773, this was labeled by the sponsors as a proton radiation therapy parity bill. This is another proton therapy bill, and it would have prohibited health plans that do provide coverage, didn't mandate they provide coverage, but if you do provide coverage, then it prohibited them from having the proton therapy to a higher standard of clinical evidence for medical policy coverage. It didn't mandate coverage. It failed in the subcommittee for a lack of motion. Again, there was concern. A lot of information is put up on both sides as to the efficacy of proton therapy. And there was a lot of concern, not only by my organization, but by some of the physician members, that it codified the standard of care. It codified the state of science at this particular time. It may take a snapshot of what may or may not be efficacious science, but that's going to change. I mean, anything in medicine is going to change over time. And if you have it in code, in the state code, then you end up having a dichotomy between what is the standard of care and what is going to get me in trouble from a liability risk standpoint. So putting the standard of care in the code is not a good idea, generally speaking. And one of TMA's legislative priorities was to fund the gap in the payment for cancer treatment of dual eligible patients. So Medicare pays 80%, and then under the general dual eligible rules, TennCare would pick up the other 20%. They don't do that. So the cost of that treatment is not fully funded. So the oncologists that do treat dual eligible patients end up losing money. So what we wanted to do was to put $800,000 in the budget, because that was what the fiscal note indicated needed to be done funding-wise in order to do that. So we lobbied heavily to try to get that done. At the end of the day, the decision made was not to fund it, unfortunately. I think there are two possible reasons for this, and we don't know the true reason, because the way the General Assembly works is that they have public hearings, committees listen to testimony and ask questions from anything that's introduced that might be a line item, potential line item in the budget. When that's done, they meet in secret on a weekend, a handful of them, and decide what is going to be in the budget. So it's literally behind the curtain, and then the public finds out at a later time, so you don't know what went into that. There might be a political reason for this. The chairman of the House Finance Committee was vehemently opposed to a bill that TMA brought forth, the Payer Accountability Act, which would have required health plans to not change contracts, fee schedules, or payment policies that affect reimbursement, except only once a year. It was a contract as a contract bill that made a lot of sense, but the chairman of the House Finance Committee, being an insurance salesman himself, was beholden to the insurance industry. As an aside, the bill passed both chambers and went into conference committee. It passed in different forms, so it went in conference committee on the last day of session. It was the last item of business for the 2016 legislature, and the two chambers could not agree on a version. We lost by 5 votes getting that bill passed in the House. I think that there was both a political and a practical reason for that. The practical reason being that if you're TennCare, from TennCare's standpoint, what's the problem? I mean, these patients are being seen, they're being treated, and it's not TennCare's issue. If the practices are losing money, their issue is having enough doctors in the network to see the patients. So as long as they're being seen, as long as they're being treated, what's the incentive? Now we're going to go into the lightning round. This is where, the bills that you hear about are the Bible bill, where transgender citizens have to use the restrooms. But there are over 300 health care bills that were monitored each year that directly, ancillarily, or indirectly affect you, your patients, and your practice of medicine, or your practice of your profession. So these are ones I want to address today in part 2, so that you'll get a flavor of the multitude of bills that are out there that are being dealt with by the General Assembly. The first being the E-Verify system. Under current law, Tennessee employers with 6 or more employees have to keep a copy of the employee or the new hire's driver's license or some kind of identity that documents that your new hire is in the country legally. The 2016 amendment says that for a company with 50 or more employees, not 50 more physicians, but 50 or more employees, that you're required to use what's called the E-Verify system, beginning with employees January the 1st of 2017. So here's your first compliance law that you need to know about, especially if you're a large group practice of 50 or more. And I've given you the internet site that your practice needs to go to in order to verify that your new hire is in fact in the country legally. Charitable Clinics. The Public Chapter 766 allows charitable clinics to employ certain physicians. This is kind of a continued erosion of the employment doctrine of physicians, which started out that you absolutely could not employ a physician, and then over the years there have been several exceptions, this being for charitable purposes. That relationship has to have specific requirements in the contract. So if that is something of interest to you or your foundations, then you need to read this law very carefully and be aware of it. Direct primary care agreements. This allows primary care physicians to go outside of any health insurance to allow the patient to contract for medical services. The way this usually works is that patients will agree to pay a certain amount, maybe $40 a month, for a menu of primary care services for the entire year. And the concern here was that, well, is this insurance, or is this something that needs to be regulated by insurance? And this bill makes it clear that no, it's not, that these arrangements are perfectly legal for primary care, and it goes into great detail as to what has to be in those agreements. Medical spas, this repeals the requirement that most physician groups who did cosmetic procedures, even on an ancillary basis, register with the state and pay a fee. We were able to get most physicians out of this, except for the ones that really don't need regulation to begin with. These are the cosmetic surgeons and the board-certified folks. They have to register and pay a fee, but family physicians and others who might do something like minor laser or something like that, they would have to register. So most of our members are out of that. Professional privilege tax, pay it. It's due June 1st every year, $400. You go online, but they're taking a good look at this. They are putting together a task force to discuss whether this is really needed or if they need to expand it. If you're a physician, a lawyer like myself, dentist, chiropractor, you have to pay. If you're a nurse practitioner or a physician assistant, you don't pay the tax. So they're looking at both as to whether to expand that or whether to just do away with it altogether. But also, a big problem for our members has been that they just, for whatever reason, didn't pay the tax. They didn't get notice. They weren't TMA members, so they didn't hear from us all during May each year to pay the professional privilege tax. So there were a lot of penalties owed. This new law requires that the Department of Revenue notify those that are subject to the tax as to when the tax is due. So it's an additional reminder. CON law, the public chapter, hot off the press. I read it this morning. I'm going to address a few things. First of all, MRIs. I've demystified it for you on this slide. If you utilize MRIs as to whether or not you have to have a CON, and it is a function of how big your community is where you practice. If it's 250,000 or more, which would be Hamilton, Davidson, Shelby, Rutherford, and Knox County, I believe, then the top column would apply as to whether your MRI needs a CON or not. Everywhere else in Tennessee, initiation, addition, or replacement of an MRI machine, I've told you whether or not you need to get a CON. It also removes the requirement for a CON for capital improvements of major medical equipment of more than $2 million. As I understand it, and again, the public chapter is hot off the press. You've got MRI machines, linear accelerators, and PET machines. Those are kind of the three that still require a CON, and I've told you MRIs under certain circumstances. But a lot of services were eliminated, and a lot of them kept in. This was a result of compromise over several organizations. I think the original intent was just to get rid of CONs altogether, but they reached a compromise instead. X-ray operators, there is a new board that is being put together. It's under the auspices of the Board of Medical Examiners that licenses X-ray operators and the machines. So if you employ X-ray operators or have machines in your office, then they're now going to be regulated by this new board that's being put together. Fortunately, the requirements for X-ray operation really don't change in this bill, and it looks to me like it may have the potential to ease some of the requirements. So if you employ nationally certified X-ray operators, you're not going to have any problems. This is going to affect you at all. Medical student liability, if you're a resident, you have plenary immunity under state law when you're operating within your particular residency. The problem was for Williamson Medical Center in Franklin, Tennessee, was that they utilized physicians as part of their training program in the hospital, but there was no immunity provision for the medical students who, during their training, would be around. So there was some concern. So this law adds medical students and puts them in the same category as a resident in terms of liability within their training program. The repeal of the religious exemption, very proud of. There was a case in Knox County where I believe a 13-year-old minor patient had cancer. And so mom decided, well, we're going to pray and we're not going to seek medical treatment for this child. Well, the child has no voice. I mean, this is something that at the mercy of the beliefs of mom. Mom was prosecuted for child abuse and for not getting medical treatment. And that case went all the way up to the Supreme Court. There was a challenge as to the constitutionality of the exemption. The Tennessee Medical Association entered an amicus brief in that case, arguing that this exemption should be struck down. That was unsuccessful. The Supreme Court decided not to address that issue, so the next step was going to get legislation, and this surprisingly moved very smoothly and got rid of the exemption. So now, if you have patients that minor patients that are not being treated, that are the parents are utilizing prayer, then they can be prosecuted under the child abuse laws. Coverage mandates. This is the law that I asked everybody to put in their back pockets. What this does is it requires any state mandated health benefit that applies to commercial health insurance. It must, anything passed in the future, must also include any local insurance, local government insurance, state or local government, so state employees, and TennCare. All right, what does this do? Well, it creates any proposed legislation mandating benefit coverage is going to generate a fiscal note, probably going to generate a quite substantial fiscal note. So this gives the TennCare Bureau or the state employees an opportunity to put large fiscal notes on it, and it will probably be defeated, or at least it makes it immeasurably more difficult to pass any legislation that is considered a mandate. Telehealth. This Public Chapter 990, there's been a lot of legislation, probably every year for the past 3 or 4 years, on telemedicine. It's a growing industry. It brings in billions of dollars into the country, into the state a year, but it's very controversial, and there are a lot of people on both sides of this. This kind of kicks the can down the road a little bit further in terms of reimbursement for telehealth, which has been, something that's been it has been defined in years previous, and now that they never got to the fact that, well, do we need to mandate that it be covered? I mean, is it considered a service equivalent to an in-person service? Well, in some cases, maybe. In some cases, maybe not. But this puts some parameters on the insurance reimbursement for telehealth. Incremental dispensing. This allows pharmacists to incrementally dispense maintenance medication up to the prescribed dose unless the prescriber indicates otherwise on the prescription. So how this would work would be, if you have a prescription for 90 days, the patient goes in, the pharmacist can dispense 30 days worth and tell the patient to come back unless the prescription says, no, you can't do this. You've got to fill the entire prescription. It's not allowed for controlled substances, so the pharmacist has to fill the entire allotment of controlled substances. So if you get complaints from your patients that their prescriptions aren't being filled, this might be a way to probe that. It might necessitate that you put fill up to limit on the prescription. Pain clinic licensing. I don't know if we have any representation from pain clinics. I'm not going to spend a lot of time on this. This has been, again, this has been an area that's been very concerning to the legislature. They wanted to have a dichotomy between what is a legitimate medical practice and what is a quote-unquote pill mill that only exists for giving out narcotics. And they've kind of chipped away at the stone. They followed a lot of what Florida and some other states who've had huge problems have done over the years. Tennessee is consistently ranked in the top 5 in the nation in terms of dispensing of controlled substances, which is staggering considering our size vis-a-vis California and some other states. So the General Assembly has been very interested in addressing this issue and continued to do so with this licensing law that requires pain clinics to be licensed. Now, I mention this because there's some disturbing aspects of this that you should know about. This requires unannounced visits. The Department of Health can go in if they suspect that a practice should be licensed as a pain clinic, but is not licensed as a pain clinic. And here's what's disturbing. One thing it does is you would expect that the statute would say it's okay to have access to medical records for review, but this one adds business records, which I'm not aware of any other law or regulation regarding healthcare where business records are now discoverable or inspectable by the Department of Health. The second thing it does is it places the burden on the practice to prove a negative, to prove they are not a pain clinic. So the Department of Health doesn't have to go in and prove, oh, well, we need the evidence to prove that you're a pain clinic. Pain clinic has to defend itself and say, well, we're not because, and here's the data. So very disturbing, and it's disturbing because, well, it hit pain clinics this time. But when is it going to hit you, or when is it going to hit family medicine, urology, other specialties? And this is something that we have to be aware of and vehemently fight against. They changed the qualifications for medical directors only if your medical director is a medical director by virtue of being a board certified by the American Board of Interventional Pain Physicians, ABIP. Under current law, your medical director would have to pass Part 1 of the exam. After July 1st of this year, they would have to pass Parts 1 and 2 of the exam. And again, just to be clear, if you're one of the core specialties of board certification, this doesn't apply at all. This doesn't address you at all. In-office dispensing, this applies to the in-office dispensing of opioids and benzodiazepines. The regulators are very concerned. They don't want controlled substances dispensed in medical practice. I mean, they equate that with a pill mill. They equate it with trying to get under the radar in terms of reporting to the controlled substance database and getting around the pain clinic laws. So what we've done is we've gone in and made it clear in the law, where we were in dispute with the health department for the last year, that yes, you can dispense controlled substances. And we repealed a definition of unit dose, which was extremely contentious by the practices that dispensed. So it's a good balance, because it allows legitimate medical practices to continue to dispense controlled substances, but it still protects against being, the pill mills. It requires that they be that those the dispensed drugs be reported to the controlled substance database, which we believe was already in the law anyway. Prescription Safety Act of 2016 is a mere rewrite of the Prescription Safety Act of 2011 or whenever it was. There weren't a lot of changes that really affect physicians. You still have to make those reports to the Controlled Substance Data Bank if you dispense. Not a lot of changes. Tennessee Medical Association, for members, does have an online law guide topic on prescribing. And we amalgamate all the prescribing laws and kind of break them down, demystify them. So if there are any questions about how you should prescribe, what is the regulations, that's a good summary of it. Advanced practice nursing, scope of practice, there were a couple of laws addressing that. There were two competing bills filed this year. One would allow nurse practitioners, advanced practice nurses, to practice independent of supervision relationship. And then there was a physician-led team-based care bill that was introduced. And as a compromise, the General Assembly said, we're not going to pass either one. We're going to form a task force, get these stakeholders together, and then perhaps make some recommendations for next year as to what can be agreed upon to make the oversight an easier process for both physicians and nurses. Know that the penalties for TennCare fraud have been increased. That would include submitting bills for services not performed, false code, upcoding, things like that. But we were able to get some language in there to protect you. The law specifically exempts prescribers who issue a prescription or dispense a drug in good faith. So a mistake or something that is defensible is not going to rise to the level of fraud and invoke the increased penalties that concern me as a lawyer. The coverage assessment, this is the annual, whatever you want to call it, assessment or tax on hospitals. That's very important to healthcare providers because, one, it funds up to $50 million for graduate medical education training. There's, and that hasn't changed in probably 20 years. So we're paying the same price that we were 20 years ago for graduate medical education. I guarantee you it's gone up considerably since then. It also buys back benefit limits. So limits that are going to go into effect every July 1st that would limit the number of office visits, hospital night stay, imaging, all that they were going to be limited, so up to maybe 10 office visits, and after that, it's up to you to collect from the patient. How are you going to know that? This buys that back so the benefit limits don't go into effect. So this is an extremely important law each year to make sure that it passes. Technical advisory groups. I hope everyone is aware of the TennCare Bureau's payment reform innovation episodes of care. If you're not, this is the wave of the future. This is the way everything is going. The government, the health insurance, everybody is pushing this to either reward or penalize quote-unquote outcomes. Many of you might have participated on technical advisory groups. This law requires the TennCare Bureau to address each of the recommendations by tags or technical advisory groups, say why they did not implement the suggested recommendations. So it adds some accountability for those who serve on tags. Potential issues for 2017. A lot going on, most notably and recently, Speaker Harwell has a task force to, again, look at things like Insure Tennessee, vouchers, to expand health insurance in the state of Tennessee. Balance billing, I don't know if that's a huge issue for you, but there's a faction out there that would like to stop that or at least curtail it significantly. So that's going to be a big issue that we're going to dive into and get involved in. And then, the maintenance of certification has been a huge issue. A lot of medical specialties, they have to pay a lot of money to have exam prep, to take an exam every 5 or 10 years to maintain their board certification. And there's a lot of debate about whether that's efficacious. I mean, we have continuing education laws here in the state of Tennessee, which allow you to go and pretty much pick and choose what courses you want to take based on what kind of medicine you practice, what kind of patients you treat. Maintenance of certification, if you're board certified in oncology, but you're narrowly focused the last 20 years in hematology or something like that, but you have to go take an exam on the entire spectrum of oncology. A lot of people think that that's unfair. So I think this maintenance of certification, maintenance of licensure issue is going to be addressed aggressively in the next session. Last, I'm going to talk about factors in the passage or defeat of cancer treatment legislation. This was a topic that was discussed very eloquently by Mary Catherine in the previous session, but I do want to add a few more points. The mandates, remember that mandate bill I talked to you about that generates a fiscal note? This is now something that the health insurance industry is going to use to try to defeat legislation like this. This is another gun in their, or arrow in their quiver, so to speak, that they can use to defeat legislation like this. They just spout off the M word, the mandate, 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 every other word. The health plan mantra of premium increase. We heard this a lot in the committee debates and in all of the bills about we're going to pass the cost on to our customers, who, by the way, are generally speaking employers or groups, not so much the individuals. I talked about codification. You'd be wary of that because it changes. The sessions, they go at pit crew paces. You can't afford to amend legislation. You've got to get it right the first time, because amending it just delays the process. You've got to get these things passed in both chambers, and that's hard to do in a 3-month period. If you get in the middle of session and realize that some amendments are going to need to be made, getting that done, getting it calendared again, and then having enough time to pass it, get it through the various committees that need to be done is very difficult. So you've got to distinguish between a mandate. You've got to have an argument for discrimination. If we change the way that cancer drugs are paid for, what is the next terrible disease that's going to come and say, well, we want the same thing, and is this going to open Pandora's box? That's a real fear in the General Assembly, is something like that happening, deciding how are we going to weigh one disease from another. So what improves your chances? Engagement and investment. Engagement, by that I mean not just going to your legislator when you want something. You've got to have a relationship. You've got to have, you as the physician, you want to be the go-to person for all the healthcare legislation. You want to be on speed dial when your legislator is faced with a medical issue or a healthcare issue. And the way you do that is having a relationship. If you know legislators from church, from Rotary, from other relationships, if your legislator is your patient. I always said the best way to get a legislator to listen to you in the office is you put a tongue depressor in there and you start telling them, the way it is. But it's true. I mean, these types of relationships are extremely important, and they don't want to see you just when you're asking for something. In other words, grassroots activity, not only from you but from your office, your patients. They want to hear from constituents. If you make this someone from Memphis contacting a legislator in Mountain City, it's not going to work. They want to know from their constituents. And when you go to get patient grassroots advocacy, make sure that the patients that you use, if at all possible, are registered voters. Because the legislature is going to text their staff and say, okay, I've got this patient in my office, are they even registered to vote? So, it's the little things like that that can make a huge difference. Investment. The way to get access to a legislator is through political contributions. It's the way the game is played. I hate to say it. Sometimes you have to hold your nose, but realize that you're making an investment in the future. A few dollars contributing to a political action committee that's going to help medicine issues can have huge returns. What if the state budget had been funded to pay for those dual eligible patients? So you're no longer losing tens of thousands of dollars each year. So a $500 or $1,000 contribution you've invested in that return. Well, that has to be a long-standing relationship. I mean, you don't have to convince 132 different legislators. You have to convince the legislators in the committees that your bill is appearing in. So if you're appearing in Senate Health all the time, these are the guys you need to make a relationship with. These are the guys you need to fundraise for, to contribute to. What else? Meeting with your opponents. Don't wait till session to drop a bill that's going to surprise your opponents. I mean, you're going to know who they are when you come up with the bill. So the best thing to do is go and sit down with them and say, this is what we're planning to do, and can we work something out? Is this something that is going to work? Because the first thing they're going to ask you in your office, well, have you sat down with insurance? Have you sat down with trial lawyers? Have you sat down, fill in the blank. They're going to ask, have you done that? And if you say no, they're going to say, well, go do that. And if the pit crew pace of the legislature goes up, you're not going to have time to do that and then bring a bill. So that needs to be done during what I call the off season. You need to sit down and have those conversations. And document the problem. If you bring a banker's box full of EOBs that show, well, my IV and injectable patients are paying this. This is what they're paying in out-of-pocket expenses. This is their copay. Oral cancer medications, look, this is what they're paying. I mean, it's no longer conceptual if they can see it and they can visualize it. And most legislators are not doctors. We're fortunate enough to have 6 in the state legislature, which I think is one of the largest in the nation in terms of physician representation. But that kind of documentation, you know, that drives the point home, and they can see that. My selfless plea for PAC donations to help legislators that are friendly to medicine and to establish those relationships. I encourage you to give corporate donations, now legal, individual donations, both. We love to have that. It's a good investment in medicine. We'd like to thank Southern Oncology. It's one of the corporate donors from 2014 and 2015. And several other practices across the state have done that. I know I've gone at a blitzkrieg pace, but there's been, I hope that the point of this is that there's been a dearth of healthcare issues out there that the General Assembly has to deal with. And you hear about your issues, you read about your issues in your journal, but there's a lot going on out there. There's a lot that affects medical practices, compliance issues, and things like that. So I hope I've encouraged you to get involved in the process, both from a grassroots standpoint and from an investment standpoint as well. So as those of you who remember Dandy Don Meredith, good night. The party's over. Thank you.